of the OHA statewide sepsis initiative. Welcome. Today we have a very interesting topic. We have colleagues of ours from the Virginia Mason Institute located in Seattle, Washington, who have graciously joined us today to talk about their Sepsis Power Hour. We all know the importance of early recognition and early appropriate intervention when it comes to sepsis treatment in order to prevent progression onto septic shock and mortality. And to that end, our colleagues from the Virginia Mason Institute have taken a great effort to streamline and to sustain their work in getting timely antibiotic administration. So we're happy to have them here today. Before we do that, we did have just a couple of general announcements. We'd like to talk to you a little bit about some upcoming webcasts that we have coming. This program, of course, has been approved for 1.0 hours of continuing nursing education. And this particular program can be evaluated by pressing the link that you see here on the screen through SurveyMonkey. It will be live for 2 weeks following today's program. So you can complete the continuing education at any time during those 2 weeks. It is necessary to complete the evaluation, and it is necessary for you to provide your current email address so that we can email you your certificate. It will be open again from 2 weeks from today. And again, we no longer use a fax submission process for this. So that's the continuing education for today. Please, if you're planning to claim CE, please make sure that you complete this process. Also, we wanted to talk to you about some upcoming webcasts that may be of interest to you. You'll note that on March 28th, there is a program on fluid resuscitation and sepsis that's being presented and hosted by the Sepsis Alliance nationally. That will be from 2 to 3 o'clock p.m. Eastern Standard Time, and there is a link provided for you here to register in advance. There is no cost for this program, but they do appreciate registration. Also, following that, on April 10th, there's a program that is being shared with us by the Children's Hospital Association HIN, or Hospital Improvement Innovation Network, entitled Pediatric Pre-Hospital Sepsis Screening and Management. We are very grateful to join with the Pediatric Hospital, the Children's Hospital Association HIN, in sharing their work and their journey in addressing sepsis mortality in the pediatric population. And so we encourage you to attend. Registration is required, and the link is again provided for you. So we encourage your participation at both of those programs. At this time, it's absolutely my pleasure to introduce to you Melissa Lim. Melissa is with the Virginia Mason Institute as a transformation sensei. She has national experience in healthcare strategy consulting and has worked on a number of projects and initiatives that have led to improvements in healthcare delivery, and not only healthcare delivery, but sustainability of those improvements. Melissa holds a Master of Science degree in healthcare management. She is certified in the Virginia Mason product system and in taproot root cause analysis. Her work with this sepsis initiative is particularly interesting. We are very grateful to welcome Melissa today. Melissa, I will now turn the floor over to you.
Thanks so much, Jim, and thank you all from the Ohio Hospital Association for inviting me to speak with all of you at today's seminar. And happy first day of spring, or as I tend to call it, pothole season. So hopefully you're all doing okay that we're there in Ohio as well. I'm very excited to share with you Virginia Mason Health System's unique approach to stop sepsis in its tracks and improve mortality and patient outcomes as a whole. I'm sharing with you really the work that's been completed by our clinical and administrative improvement teams, and I hope at the end of our hour together, you'll have some new ways of thinking about not only early recognition and treatment of sepsis, but some broader thinking on how to engage your teams to solve problems using a tried and tested improvement method. Let's first start our discussion on sepsis by drawing your attention to our strategic plan here at Virginia Mason and the importance of aligning our improvement work to it. As you can see in our pyramid, we believe that all our collective behaviors and actions in our organization must be measured against our patient-first belief, signified at the very top. In 2014, an explicit executive physician and nurse leadership dyad was created to lead the sepsis improvement work focused on early recognition and treatment of sepsis. Sepsis goal work remained a top strategic priority from 2014 through 2017, when results showed process stability and improved outcomes. And this was really an essential aspect of establishing the necessary alignment and cultural elements for achieving the results. Our vision, as you'll see at the top, just below the patient-first belief, is to be the quality leader and transform healthcare. And this resonates very deeply with all of our staff members from the very top of the organization and throughout all of our frontline staff members. Today, you'll learn how we've adapted Virginia Mason's Sepsis Power Hour into services that we can provide to help you accelerate sepsis prevention and transform your patient outcomes. Move on to the next slide here. For many of you listening today, you are well aware of the staggering statistics. Sepsis is a complex and deadly syndrome that stems from the body's overwhelming response to an infection. With more than 18 million cases of sepsis worldwide annually, we see here in the States 250,000 of our own citizens killed each year. Patients diagnosed with sepsis see a high probability of mortality at rates of 28 to 50%. And even more insidious is that patients with initially less severe sepsis make up a majority of sepsis deaths. One study in particular that raised our eyes even showed that septic shock wasn't even present in 68% of patients who eventually died from sepsis. So improving the standard of care for patients with less severe sepsis could drive down hospital mortality rates significantly. We'll come back to that point later. Next slide. The urgency to improve sepsis care was present at our institutions as well. So between 2008 and 2014, we had 2,276 deaths attributed to sepsis, the major cause of mortality for Virginia Mason at 47% of total mortality cases in that period. Early in our journey, we began at the most obvious place of this grand problem. Our focus was placed on treating patients with severe sepsis and septic shock in our critical care units. That helped us initially to make a minor dent in our mortality. We realized, however, that although that was extremely important work, we could decrease the impact of sepsis on our patients and our communities much further if we could prevent patients from a CCU stay altogether. This required us to adjust our thinking of the core problem and move upstream to consider scientific process improvements and strategies for early sepsis recognition paired with early sepsis treatment. Move on to the next slide. Our survivor experience also helped us bring further clarity to our focus. At Virginia Mason, we strongly believe that our patients and their caregivers are important stakeholders at the table to help us understand their experience. And what did we learn from them? We learned that sepsis survivors experience longer lengths of stay with high utilization of healthcare resources. They experience higher rates of readmission, and many patients experience lifelong side effects well after their recovery from sepsis. Hearing patients share their experiences in their own words truly underscored the tremendous human cost of sepsis and inspired future improvement work for us. Integrating the patient voice and experience into this work through interviews and inclusion of patient and family volunteers on formal improvement events helped co-design a better care journey. So leveraging our lean improvement method, which, as Jim mentioned earlier, we call the Virginia Mason production system, left to accelerate and succeed in our sepsis improvement. Next slide. Our goal was to reduce sepsis-related morbidity and mortality in our patients by consistently delivering timely evidence-based care. We use the Virginia Mason production system to really think about the right goals, the right time, the right place. And our work was based on the internationally recognized 3-hour Surviving Sepsis campaign. Studies have shown that speed is life when it comes to sepsis treatment. So that was a major calling and focus for our teams. Recognition consisted of screening for systemic inflammatory response syndrome, or SIRS, and identifying a source of infection. Part of the improvement design was to improve our recognition processes using the SIRS criteria you see here, and using alarms to signal a possible sepsis diagnosis. We had to fully test this process, and we designed it eventually, after lots of testing, into our electronic medical record to allow us to screen for sepsis and see infection source clearly, really allowing for that human and machine interface to work together as opposed to against each other. What makes this recognition and treatment bundle unique and effective is that the RN, the registered nurse at the bedside, is the one screening for sepsis and initiating 3 out of the 4 elements of the sepsis intervention bundle. That's the IV fluids, lactate tests, and blood cultures right out of the gate. So no waits and no delays. Next slide. As I had mentioned earlier in the statistics, 2/3 of septic patients who died typically did not present with septic shock on arrival. Additionally, a literature review that we pulled suggested that for every hour of antibiotic delay, mortality increased by over 7%. So given that our improvement method, the Virginia Mason production system, is based on one of the core beliefs that zero defect healthcare is possible, Virginia Mason opted for a more aggressive target of 1 hour over the 3-hour sepsis campaign recommendation, and truly challenging our improvement teams to do something that was considered highly improbable, if not impossible. So we're looking at here the target boundaries of that 1 hour target, from recognition of sepsis all the way to antibiotics delivered. Next slide. The purpose of this slide is to orient you to the overarching overview of the Sepsis Power Hour process. As I mentioned earlier about the nurses activating 3 of the 4 elements of the sepsis bundle, the nurse-initiated protocol seen here on the left, which the team called SNP, or Sepsis Nurse-Initiated Protocol. And this was delivered in 30 minutes or less and was highly instrumental in decreasing time to treatment, and allowed us to demonstrate that time of sepsis recognition to antibiotic delivery could actually occur within 1 hour. You'll also note the multidisciplinary aspect of the Sepsis Power Hour with the physician's 3 major priority tasks, formally, especially with the confirmation of sepsis and helping to start the antibiotics, making a declaration on any additional IV boluses, and then the pharmacist's priority work of the antibiotics. Next slide. So you'll see here in the graphic, one of the critical successes of designing the Sepsis Nurse-Initiated Protocol is that it allows for synchronized and standardized work to be executed in parallel by the registered nurse, the provider, and the pharmacist. by breaking the mental models we previously had around providing clinical care in a linear process that was previously dependent on the provider being there at the bedside during the initial few minutes of diagnosis. This nurse-initiated protocol demonstrated significant contributions to the results of rapid treatment here at Virginia Mason. And at Virginia Mason Institute, we've developed a solution to help your hospitals to improve sepsis. It not only includes how to implement what we've discussed so far, but it also includes coaching and facilitation to help you build integrated teams and processes. Next slide. I wanted to spend a little bit of time to really talk about the engagement work that was done with our teams. In addition to the critical QI work that was done to redesign our response to sepsis, we recognize that strong team engagement to act quickly is absolutely key. There are two key elements that contributed to the success of the Sepsis Power Hour. It's empowering the care team to take action and rapidly bringing services to the patient. Our sepsis treatment bundle shortens the reaction time at each step of the sepsis response process, removing the waste that was previously inherent in our work, from the early detection of sepsis to empowering nurses to swiftly initiate treatment to the consistent and rapid delivery of care. Next slide. Now, communication and accountability across the sepsis team is a driving force for improving quality and timely care delivery. Our sepsis stakeholder team members include registered nurses, nursing assistants, phlebotomists, providers, pharmacists, and the project manager. Each role has accompanying dynamic standard work, which allows for transparent accountability of each stakeholder. It creates that reliability of each of the team members, that they know that that other team member is going to do the work that we've held them accountable to. And the importance of that type of role clarity cannot be underestimated, as an established and reliable sequence of work helps the team to identify and respond to any potential process variations as they occur. And that's really a major tenet of our work with the Virginia Mason production system, is continuing to improve, identifying new outliers or new wastes or problems in the system that we can continue to tackle and improve the sepsis response design. Now, the next slide here shows that along with many important responsibilities, one of the major functions the project manager has played over the several years of our sepsis work is to provide closed loop communication directly to providers and staff to recognize them when the quality standard is met. Project manager feedback is crucial, as feedback to providers and staff reinforces the right behaviors and activities we expect that are needed to improve and embed this work over time. And so you'll see here, Alice Ferguson, our project manager, just sending a quick note to Dr. Calderon, one of our fabulous hospitalists on our team, just thanking him for using the evidence-based order set that we built into place and ordering the antibiotic stats. And so you'll be able to hopefully celebrate the fact that they were able to administer the antibiotics within 30 minutes, which is well under our 60-minute target. Next slide. I mentioned Alice Ferguson. Again, she is the sepsis team project manager who continues to monitor the important work that we are still continuing to do and helping to ensure that sustainability and the team engagement that we hold very true here at Virginia Mason. She reflected here, I think the best thing about Sepsis Power Hour is that it brings care to the patient without the patient having to wait. It really leverages the whole multidisciplinary team, exactly where their skills and strengths are, and the ultimate beneficiary is the patient. And I can't help but reflect back on our strategic plan, where again, at the very top of the pyramid, it is about patient first, and whether or not our processes are really helping to ensure that patient safety and care is at the top of our mind. So I'll actually just take a quick pause here so you can hear some more thoughts from our members of the sepsis team.
Just having some issues with the audio, unable to hear.
I think in the span of time that it takes to call and notify and page doctors. And I've also seen patients react better. They're more at ease when they see nurses and doctors kind of more directed in what they're doing. They feel more confident, and their family members are more put at ease.
And it's a great conversation to have with the patient's family as well, to say, we're gonna do this right now. It might be a little disruptive, but this is the way that we want to take good care of you as soon as possible.
All this work has been successful in that we are seeing time to giving antibiotics within the first hour being accomplished at a high rate, and to be saving patients' lives and having that kind of result shows that this is something that's very successful and should be continued.
What has really changed for patients and families? Just in the numbers. Mortality rate has been decreasing year after year for 4 years straight, and it had plateaued for a good 4 or 5 years prior to that. So that is a substantial improvement. Our rapid response call rate has reduced from 120 a month to 40 a month. So it's in the numbers. Care is better.
I think the best thing about Sepsis Power Hour is that it brings the care to the patient without the patient having to wait. It really leverages the whole multidisciplinary team exactly where their skills and strengths are, and the ultimate beneficiary is the patient. So they get the care when they need it without having to wait, and it's amazing from the perspective of all the staff and the patient.
Thanks everyone for being patient with us while we were trying to deal with the audio issues. We'll be sure after the presentation is over to send the YouTube link so that if you'd like, you can rewatch it, because I believe we missed the first half that included a number of the team members who are very heavily involved in the sepsis work back in Seattle. So what has the Sepsis Power Hour done for our outcomes? Well, since the project began, Virginia Mason has achieved a lead time from sepsis identification to antibiotic administration down to 47 minutes in the emergency room. And in the hospital itself, we reduced the lead time from 140 minutes down to 64 minutes, a 54% reduction. I'll also just add a little side note here that when we truly first began our sepsis work, the amount of delays and waste that we have within our processes came down to a baseline lead time of 8 hours. So we truly started at the bottom of the barrel here. I'll also just share with you a couple of additional benefits that resulted from the improvement work. It's included a decrease in our hospital rapid response team calls from 120 per month down to 35 with no residual increase in code blues. The average 90-day sepsis episode cost at Virginia Mason at the time that we had checked this number was $22,082, and that's in comparison to the national average of $28,130. So it's about a savings of 21% per episode. And Virginia Mason has experienced a 15% reduction in discharges as well to long-term care facilities, again, thinking about the sepsis survivor experience. And this has really helped to alleviate access to care across Washington State's communities as well. Finally, and most importantly, we did see a decline in sepsis mortality by 45%, and we continue to push harder on that work. As our improvement method has taught us, we continue to strive for excellence and zero defects in this body of work. Since 2017, we've expanded our sepsis model line work to look at sepsis recognition and care outside of the brick and mortar of our hospitals, out to our ambulatory clinics. And we're continuing to do that work as we speak. So we'll wrap up here with this slide just to say thank you again for allowing me to share with you our work of the Sepsis Power Hour bundle. If you're interested in accelerating your own sepsis improvements, please contact us. We've adapted the program and you've been learning about to help others achieve the rapid recognition and treatment of sepsis in under an hour. And through coaching and consultation, our experts can help your organization develop the structures, the processes, and the outcomes to accelerate your sepsis improvements, while truly engaging your team members to be part of that work. Our collaborative partnership is designed to empower you to develop your organization to ensure success in the battle against sepsis. I can tell you from our experience, a 1 hour time to treatment with improved mortality is possible. And you'll see on the slide up now, feel free to check out our website at virginiamasoninstitute.org. We've got a number of case studies and interviews on our very work of sepsis, as well as a whole other slew of work in the improvement space on that website. And I'll kick it back over to Jim.
Well, Melissa, thank you so much. What a wonderful presentation, and certainly some phenomenal work being done, and the sustainability of which we cannot underscore. You know, you talked a lot about the importance of the alignment of your work with the strategic plan, and that is something that we know is so important to leadership-driven efforts, specifically with mortality reduction in sepsis. You also talked about your efforts being very, I believe you used the word synchronized and standardized. And I found that very interesting when you showed the progression using the nurse-driven protocols and the decrease in time. And we also have a number of hospitals here in our initiative who also reinforce what went well and not just what did not go well. And I thought that was really interesting. So thank you for sharing all of that. We do have several questions that have come in, and I think at this time I'll go to those questions. But to remind everyone on the line, you're still welcome to type in any questions you want through the Q&A line or the chat line, and we will certainly address those now with Melissa. So without any further ado, the first question that has come in is about rapid response, and it says, what do you attribute the decrease in rapid response team calls to?
That's a great question. And one of the things that I'll just call out here is when we talk about that recognition process and what actually happens when the blip, the alarm comes up. And so part of it has to do with just that standardized response to activate the sepsis team, a sepsis page that immediately goes out to each of the multidisciplinary stakeholders that are involved. So we actually have the standard work that you can read through that shows you that between the physician, the pharmacist, the flow manager on that floor, and the individuals who are there present at the bedside, they react immediately to that sepsis page. They have very exact steps that each individual has to respond to it. And so I think that created so much clarity that we didn't need to rely on the rapid response teams as much as we had to in the past when we didn't really have that role clarity.
Yes, and I think that really gets to your point of synchronized and standardized, right? Because folks have, it's very clear cut as to the synchrony and the standardization of the efforts, if I'm understanding you correctly.
Yeah, absolutely. And as the first half of the video that we couldn't quite hear at that time, you'll hear one of our nursing assistants, for example, just kind of share his thoughts about his own contributions to the sepsis work. And you'll just kind of catch kind of in his voice that regardless of who you are, you play a significant role in that patient's life. And so having that standard work allows for that synchronization to kind of just play out really beautifully and kind of remove any of the confusion or chaos that might occur in some of these life and death situations that we tend to see in our hospitals.
Thank you. And kind of along the lines of the response team question, a question came in asking if there is a correlation between the increase of the sepsis team activation and a decrease in the code team response? Specifically, did those responses get shifted to a different team?
That's a great question, John. Thank you for asking that. I'd also probably just clarify, it's not so much about shifting the work to a different set of team members, but it was really about ensuring the clarity for the local team members who were right then and there at the bedside. So not needing to depend on essentially kind of an external team to come in and swoop in and save the day, but just, again, kind of going back to my previous response, that because of that standardized work for each of the individual players at the unit, whether it's in critical care or just in one of our basic med-surg units, they know exactly what needs to be done. So when you activate the page and the response for sepsis, we're not needing to essentially outsource the response, if that makes sense.
Great, thank you. Our next question is one that I knew would come up, but it's a question about resources. And the comment is, not all hospitals have unit-based pharmacy. Were there any issues with pharmacy coverage to accomplish what you've accomplished?
It's an interesting question there about our pharmacy. So I will say that we do have an inpatient pharmacy. It's kind of centralized within our Seattle-based medical center. So with that being said, I'll also just call out that as part of the improvement work and some of the early discussions on how to tackle sepsis, we kind of had to work through some crucial conversations about what an individual role brought to the table and whether or not there were some traditional or conventional ways of thinking on who needs to do what and where. And so as it comes to the pharmacist role, we really talked a lot about, okay, so what does it take for us to create that central response, and what are the individual steps that require us to get there? And so some of that work that was able to break through for us was about the individual steps within each stakeholder's work.
Yes, and you mentioned a lot about role clarity, and can you expand on what specifically you did to accomplish role clarity?
Yes, so one of the things that we learn a lot about our Virginia Mason production system are the assumptions that we make about each other and the roles that we play. And so much of the work that really just needed to be done was to call out some of those assumptions, and then either to confirm those beliefs and then build that in a little bit more firmly into the work that we do, or what we call myth busting. It's fairly typical vernacular at Virginia Mason. So busting some of the myths that we have about each other. And you'll note that in that graphic earlier of the sepsis nurse initiated protocol before and after, there were some assumptions that we made about, oh, only the physician can do this, or the provider on the unit can do this. So we have to sit and we have to wait until they arrive in order to have a confirmation of sepsis, et cetera. And so kind of breaking down the silos between us versus them mentality, and really kind of reflecting on the team as a whole and what our collective responsibilities are, allowed for a little bit of the trust to be rebuilt between each other, and it really just kind of realigned some of the basic steps that we made assumptions about needing to be under one individual versus another. And so that's really kind of where the role clarity comes into place, and really helped us to design some of the standard work and the policies actually behind it as well.
I'm glad you brought up the nurse-driven protocol, because the next two questions that we have are related to that. The first one is, what would you say are the selling points, and that's in quotes, to physicians who tend to oppose nurse-driven protocols? And then the second one about nurse-driven protocols is what RN competencies are used for your sepsis nurse-driven protocol?
But great question. So you might have to remind me of the question after I answer the first one. So let's just go talk a little bit about team engagement. So one of the major tenets of our work with the Virginia Mason production system and what we've learned from Lean and Toyota is that ultimately at the end of the day, this improvement work is centered around the concept of respect for people. And really understanding, walking in other people's shoes, listening to understand all of these behaviors that we role model with each other every day between housekeepers, nurses, nursing assistants, etc. And so when we come together as a team at Virginia Mason, and specifically here in this case, trying to figure out how to solve the puzzle of sepsis, at the end of the day, our physicians really truly believe that we're all in it together as a team to fight these massive problems. And so it's less for us about needing to kind of do land grabs or kind of sort of really like place your ground on what your domain is on, but really trying to look past that and understand what the common goal is on behalf of the patient. So at the end of the day, physicians are generally interested in collaborating and trying to improve care. And it's really about trying to communicate that in a way that really resonates with them and to bring them on board as part of the work. So it's not to say that we didn't have difficulties in trying to bring physicians on board. I mentioned earlier about needing to link it back to a core organizational quality goal and the nurse leadership and executive physician dyad. So we are really purposeful in choosing leaders who either had authority or influence or both, so that we could really kind of start to prepare our team members to understand what the crux of the goal was and how we could kind of band together to kind of tackle the problem and the processes behind it and not the people who are helping to serve these patients. I'll pause there and check in with you, Jim, if that answered that first question.
Yes, no, specifically, thank you. I appreciate that. I'm just curious if you had to leverage any data, I'm adding on to this question of what they call the selling points, but, we hear about nurse-driven protocols with other clinical quality work, such as nurse-driven protocols for urinary catheter removal and that kind of thing. And often, folks are needing to cite data that shows that nurse-driven protocols have been efficacious or not. Did you have to do that in your journey? And if so, was there any data in particular that you would cite or suggest to us?
Oh, sure. And I will say that the earlier slides that we talked through actually were pulled directly from some of our own presentations when we were building the case against sepsis for our teams. So it's kind of galvanizing the groups around what is it that is in front of us, and how do we all come together against this common enemy. We are a fairly heavily data-driven organization. Again, because of our Virginia Mason production system, it really teaches us to not move by purely anecdotal evidence, but really going in deep, going to the Genba, or what we call the shop floor, and to observe with our own eyes what exactly is happening in these processes and where the waste is lying in the work that we do. So as it related to kind of building a sense of urgency is crucial in communicating to our staff members, but really also pulling our own individual data to kind of just share with the teams, like, this is where we're starting from, and it's not great. So what are we going to do about it? And how do we work together to really start to improve some of our metrics and outcomes? And so that really kind of helps us to kind of build the case against sepsis for all. And I'll just also note, you all may have heard some of the quotes about, the only way that you feel like you've communicated successfully is 7 times in 7 different ways. And even then, you might not have communicated sufficiently to all of your team members. So we recognize that some people are heavily data-driven. Some people, pulling from John Cotter's work, they just need that see, feel, change moment. They need to truly feel emotionally that this is something that we have to act upon and we cannot delay. So we're really thoughtful as in our improvement work to really communicate in a variety of different ways to bring people on board, whether or not they're head-driven, they're heart-driven, or they're hand-driven, etc.
Thank you. The second part of that question was about, they asked what RN competencies were needed for the sepsis nurse-driven protocol. Are you able to comment on that? Or maybe that's part of the resource that you have on this screen?
Yeah, so I certainly check out our website for some of those resources. Just to give you a little bit of a sneak preview in terms of our nurse competencies. So we definitely use kind of transparency and visibility of skills matrices to kind of make sure that we have some basic nursing elements, fundamentals, or I believe we call them foundational elements of nursing at Virginia Mason. So that comes from the basics of daily rounding and communication handoffs, medication administration, et cetera, to code card protocols, sepsis, et cetera. I will say in particular to the improvement team work where we're needing to undo a lot of the habits of our existing staff. I'm sure that everyone can kind of agree around the room when it comes to, okay, well, how do we get everybody at the hospital to change their previous perceptions of how to tackle this process. We actually did a lot of kind of sepsis response drills, ad hoc, impromptu, so that really just keeping people spontaneously to kind of ensure that they really understood their individual roles and how to do them competently to the point of muscle memory. So, certainly making sure that the improvements that we built in were as mistake-proofed, easy to use, at point of use for all of our staff members. So they don't have to memorize, pages and pages of protocols, but also ensuring that the training and the coaching behind it to ensure a safe journey of embedment and sustainability was very much there to support our staff.
Thank you. Our last question that we have is, you mentioned survivor experiences. And the question is, do you use a PFAC, or Patient Family Advisory Council, to advise your sepsis work? And if so, how?
It's a great question. So we do have a program called our Patient Family Partner program. It is about, last time I heard, it was over 200 partners strong. And this is a really engaged group of individuals who understand that a lot of our improvement work is wholly centered on the Virginia Mason production system. So they recognize the value that they bring by bringing not just their personal experiences, but fresh perspectives, pulling from their patient experience, caregiver experience, even their own professional background to kind of help us challenge the ways that we think about healthcare. So we are extremely grateful for that group, and we do involve them in a variety of different ways. From some of the basics that some of you may be very familiar with, so bringing them onto committees to kind of help with patient-centric literature to focus groups and interviews, using some of the experience-based design methodology to kind of make sure that we're really capturing as much value as possible in their perspectives of their journey. And then we also actually ask for our patient and family partners to volunteer to participate in our improvement events. And that actually means that they're a fully contributing, an active team member on an improvement team who are on the ground actually designing improvements and testing it live with patients and staff members. And so it takes a little bit of preparation because some of these events are anywhere between 1 day to a 5 full day event. But they walk away with just realizing how much they've contributed, and we are extremely grateful for the time that they give to us to make sure that the improvements are truly patient first.
Well, thank you very much, Melissa, again, for a wonderful presentation and for addressing these phenomenal questions. Thank you also to the participants today who have submitted questions and feedback, and for all of you who have joined in today. A couple of announcements about upcoming webcasts. Next month, our April Sepsis webcast will be held on Wednesday, April 17th at 11:30 a.m., same time. Our topic will be on air care in sepsis patients and transports from one hospital to another. To present that to us will be Amanda Wolf, who's the base clinical manager of Survival Flight. So we will look forward to having her presentation. It's a different perspective about out-of-hospital care related to sepsis patients. And then in May, for our May 15th call, we'll be focusing on maternal sepsis. That'll be a call that we will be co-providing with the Sepsis Alliance nationally, and we're very pleased to do that. The only change with that webcast will be the time will be changed to 2 p.m. Eastern Standard Time. We will be sending out notifications to that effect. So April 17th, same time, 11:30, a presentation with air care, and then May 15th will be a presentation on maternal sepsis with the time change to 2 p.m. Eastern Standard Time. As always, we look forward to your participation. We thank you for all of your focused work in helping to save lives throughout the state of Ohio and beyond. This concludes today's call. We hope that you all have a great day.